Today's mini lecture focuses on supply chain issues in healthcare. The healthcare supply chain is of particular importance for several reasons, not least because it is very expensive. Healthcare absorbs around 10% of the gross domestic product of a country, and supply chain is a very significant part of this, as we shall see later. There are many supply challenges around procurement and around order processing, and especially we think of here of potential errors. Now, the consequences of these failures and errors get a lot of attention. Healthcare is a very political process, and in particular there are issues around coordination and the management of the supply chain in the context of multiple conflicting stakeholders and objectives. In 2006, the United States spent over $2 trillion on healthcare, and the annual cost per family for health insurance was round about $22,000 in 2010. And if we think that in America at that time health insurance was not available for all people who wanted it, then we're talking of a considerable amount of money that is required in order to fund this. By 2016, it is predicted that $1 every $5 in the US economy will be devoted to healthcare. In a UK context, we saw recently that of the overall tax within our country, roughly 1/4 of all tax spend is on healthcare, and in particular the national health system. Therefore, health cost is terribly important, and supply chain cost as an important element within the total spend is obviously an area where if we can make major improvements, then potentially we can have more money that we can spend either on improving services or perhaps even reducing the overall cost in terms of the taxpayer. In the US, as we saw, spend on healthcare is expected to rise above 50% of the total budget in a few years. If we look at this build, we see that supply chain costs, the elements in the middle here, make up a substantial part of the total spend incurred by hospitals on the total provision of the service. Let's look a little bit at the supply chain of healthcare. Starting on the left-hand side here, as we traditionally do, we have the manufacturers, the equipment makers, the pharmaceutical companies that provide the equipments and the drugs that we need in healthcare. Then there are the distribution agencies, the people who move the pharmaceuticals to the end use, and of course disposables. The healthcare providers themselves, here we can think of the hospitals, the clinics, the surgeries, where the actual production of the service takes place, where the doctors and care workers are who provide the treatment to the end users, the patients. And we see in this diagram, in this rather traditional simple form of the supply chain, goods and services here are represented by the red arrows, whereas information flows backward through the supply chain from the actual use of the patients on the right-hand side to the various signals which are required in order to coordinate delivery of goods and services right back towards the manufacturers. In most health systems, there is some sort of health insurance approach which actually pays for all this. And healthcare users pay for this either with direct insurance payments or where there are public systems, such as in the UK, national insurance or private insurance through the health insurance system. And in the UK, the NHS is mainly funded through general taxation. Money is taken in high taxes and paid via a process known as commissioning and payment, where the required services based on a prediction of demand is made and the money is then paid to healthcare providers. It's interesting to note in the UK that a lot of commissioning is based on a demand forecast, based on what types of treatments will be needed by patients in a certain period of time. This forecast is then used to provide the facilities and also the treatment modalities that will be required. In this way, healthcare systems look to some extent just like a push system. Wrapping all of this system from manufacturers, distribution to healthcare users are the government and regulatory systems. Healthcare systems in every country in the world is a highly regulated environment. It is also a highly politicized environment. Basically, anything to do with healthcare very quickly becomes a political issue inside society. And often one can regard healthcare systems as a tool for social policy. So there is an enforcement, a heavy regulatory environment which operates within the healthcare sector, regulating the behaviours of manufacturers, the distribution, as well as the providers of the healthcare service. What can we say about the current state of the supply chain? Here we have some of the main supply chain issues that we discussed during the course, from inventory management through fulfillment to delivery. If we look at the healthcare supply chain, we see that sometimes we can regard the process as demonstrating an abdication or a lack of clarity over the responsibilities of who does what. Difficult handovers, fragmented supply chains are typical characteristics of the healthcare supply chain. There seems to be a lack of strategies for improvement. This also touches on the political issues I just mentioned. For example, if we have a discussion in the broader society about the closure of a facility, such as an acute hospital, then this becomes very quickly a political issue, and the improvement strategy behind such an action are often lost, or is often lost. Furthermore, information transparency and high resource usage are also strong characteristics of the healthcare supply chain. There are evident performance gaps across the supply chain. If we regard just commodity supply chain performance shown here as the top line, this is not top-level exemplar performance, but just general average performance across the supply chain in industry as a whole. We can look at the healthcare supply chain and see how this compares. For example, order accuracy for the provision of goods, drugs, equipments are around about 80%, whereas the commodity supply chain performance we discussed during the lecture series is typically up around about the 98% mark. Lines per order, meaning the number of lines that are placed on a purchase order, is round about 1.5 in healthcare, whereas a commodity performance would typically be around 10. What this means, of course, is the number of actual purchase orders that one must produce in order for a typical operation is magnified in the healthcare supply chain, which leads to great inefficiencies in procurement. Stock turns are low. Expiration, meaning obsolescence of goods, whereas a commodity supply chain performance, we're talking of less than 1%. And this is particularly important when one's thinking about drugs and other use of EDI and electronic commerce in general is low. And the capturing of charge. This is important in terms of the capturing of the actual treatments which a patient receives during a total patient pathway in a treatment. There's a strong gap in all major supply chain performance parameters when one looks carefully at the healthcare supply chain. However, the design of the healthcare supply chain and innovation in general is very problematic. What we need to try and do is design a healthcare supply chain with relatively high responsiveness to patients' needs, but assuring an effective allocation of resources. But we're constrained when we try to do this. The actual healthcare provision is determined in large part by large facilities. Think here of hospitals with many thousands of workers inside. We need to account for financial and regulatory constraints, particularly on issues such as ER waiting times. These are much more important than losses in obsolescence. That is a healthcare provider environment. It is production oriented and is based on the available treatment modalities that we have available to us. And as a small point right at the bottom, there's almost no demand limit on what we as patients demand from our healthcare systems. I'm going to discuss a particular issue within healthcare which is actually common to every industry, so-called maverick purchasing, or purchasing off the list, or purchasing directly, or managers contacting directly suppliers for goods and services. This is known in the healthcare supply chain as physician preference items, and they are a very big challenge for us and can be sometimes up to 6 to 10% of operating expense. In such a situation, suppliers often direct market to doctors. They will, in the US, make direct appointments with doctors to demonstrate new products that their pharmaceutical company has just created and wish to put on the market. 30 to 40% of the supply expenses can be physician preference items. Suppliers contacting physicians, showing new drugs, and perhaps overemphasizing the improvements over existing drugs is a very powerful selling approach to physicians who do not really see the cost of the item, as this is all paid indirectly by taxation. Preference items may or may not be linked to any outcomes. Very rarely is the cost benefit of a new item discussed in any detail with medical professionals. The emphasis is on usually minor improvements to treatment outcomes, and the actual cost or the increased cost of a new drug may be glossed over. This situation is represented by this simple diagram here. Suppliers can contact physicians directly, either by making an appointment or perhaps in a conference presentation. This enables physicians to directly order from suppliers or be very influential in the way procurement is managed inside a hospital to get the drugs which are strongly recommended by the physician. All the physician has to do to make this happen is to tell hospital administration staff that it is a clinical decision, and clinical governance overrides any concerns the hospital might have in terms of the cost, perhaps, of the drug proposed. In such a circumstance, we have a situation where supply costs can go through the roof, and furthermore, perhaps more importantly, product variability can increase inside the hospital. And as we know from our discussion on inventory management, high variability in inventory can lead to high costs, and particularly the last item there, increased chances and risk of obsolescence. What we're trying to do is to move towards some future state where the physician is still contacted by the supplier in terms of new products, new drugs that come up, but the physician and or suppliers must justify the inclusion of a new treatment to so-called value-added teams, and if the efficacy of the treatment is shown to be suitable and there is appropriate cost benefit, then yes, then the drugs can be supplied by the supplier, and this supply predicated by a thoroughgoing data analysis and an impact of the decision right across all of the other items that may be held by the hospital. By such means, particularly reduction in product variability and the ability of the hospital via its value-added team to negotiate properly with suppliers for appropriate discounts and appropriate cost points or price points can be discussed. However, there are major issues when trying to move towards this type of system. Doctors have a high control over admissions and the use of any specific treatment. As I mentioned just now, all a doctor has to do is say this is my clinical judgment, then that treatment will go ahead. And any objections from any party, politicians, particularly hospital administration and management, can be quickly overridden. They're heavily influenced by the supply side. They're influenced directly by sales calls, as I mentioned earlier, as well as going to conferences and learning about the latest advances in medical science. They're heavily resistant to control over their practice by any other actor, and they are not tolerated. The interference is not tolerated by any of these people I mentioned here, the administration or even the patients. Patients in particular have very little influence over the treatment they're given by doctors. There's limited standards in the use or acquisition of medical products before the product is purchased. And even where standards exist, such as by UK NICE, variation is seen. And particularly if an organisation such as NICE says that a drug may be not cost effective and cannot be included in the NHS in this country, then doctors can very easily override such objections by the regulators, and perhaps even co-opt patients to make sure that this political pressure is placed on organisations such as NICE to overcome any restrictions they might think to impose. If we look at information technology in healthcare, this is a particularly problematic area. Isolated systems, limited integration seems to be the norm within healthcare. Only very recently are some tentative steps being made towards integrating systems, which means sharing data across island technologies such that patient information is available wherever the patient is located. This seems to be a particularly problematic area. Clinical control is a very difficult issue. New systems have to get through many different vested interests within healthcare, all of whom seem to have an overriding reason for not adopting new approaches. Monitoring of how the delivery is made is very difficult in principle to implement. And finally, inventory management is poorly handled. There's limited vendor visibility and limited analysis of spend or contract monitoring within healthcare. All of these we see in other areas of industry have been the norm for many years, and within healthcare are still pretty much embryonic. Integrated solutions are required. There's a critical need to understand clinical utilization and scheduling data. Healthcare professionals are a factor of production in the healthcare supply chain, but it is very difficult to monitor their activities and their efficiencies. It is said that if the UK, for example, could implement the same clinical productivity as more advanced countries such as the Netherlands, then this could result in up to 20% cost reduction in the NHS budget. There's a need for contract management and spend analytics. This is very embryonic, and there's great scope for improvement in cost management here. And of course, benchmarking healthcare with other industries is something which has yet to really start. Lots of things to do in healthcare: inventory management, increasing the turns, proper ordering and contracting, proper quality approaches, and obviously the use of new technologies. Overall, there's much to do in healthcare, and there's a great prize to be achieved. Healthcare is drawing an ever increasing amount of money within many advanced economies. It cannot increase forever. It is not possible to consider a country where 100% of the gross domestic product is spent just on healthcare. But the way some countries, particularly the UK, are approaching this problem, one would think there is no absolute constraint at all to inventing new treatments that are required without any regard to the proper management and control of them. The healthcare supply chain is a particularly interesting and complex area for us as supply chain professionals to examine. There are many challenges: overcoming vested interests, applying basic supply chain principles, all of which can lead to a much better and improved healthcare supply system, which can in the end only result in better outcomes for patients.